So welcome to Coronavirus Conversation, episode number 16. And today is March 2nd. And good morning, Josh. How are you doing?
I'm good, thanks, Adam.
What are
16, hard to believe. Hard to believe we're that far into this.
Yeah, it's been almost a year since we started recording. Our provost, Dr. Karen Campbell, had this idea and invited me, and then I decided, well, I can't have a proper conversation without at least one other person present rather than talk to myself. I invited Josh on. I met Josh on the pandemic task force, and it's been fun doing these. And whoever is listening or watching, thank you. And again, if you have any questions related to the vaccines or the virus or anything, just please write in. We'd be happy to do this, but we do this for the community. So how are things going at the Gable Health Center these days, Josh?
It's busy, very busy. We've moved off of return to campus testing, and now we've moved into surveillance testing. It's been pretty difficult because the NCAA has requirements for athletes that are participating in sports, and the MAC conference took some of those recommendations and truly built on those recommendations. And so there's a lot of requirements to test athletes to make sure that athletic competition can continue safely. The other part to it is that they've opened up the possibility for fall sports participating in the spring, which is something that a lot of colleges are doing. So it adds up a lot. We're doing our athletic trainer, I shouldn't say we are doing, because I'm just doing COVID testing for them. Of course, I see our athletes that are injured or have medical issues, but our athletic training staff is truly working double time right now because they have winter, spring, and fall athletes all either competing or getting ready for competition. We did 90 tests on Monday. We did 90 tests on Monday, and we'll be starting our surveillance testing of the general student body starting this Thursday. So we do a lot of COVID testing. And of course, we have students coming in with the symptoms. Unfortunately, there's some pharyngitis going around on campus, which of course with those types of symptoms, COVID has to be ruled out first. Sure. But pharyngitis is a less common manifestation of COVID, and so it's just causing more students to have to come in to get checked. But I'm glad we were able to do that quickly here on campus.
Absolutely, yeah. That was a major advance for us in our effort to try to stay in person and open, the ability to have testing on campus, for sure. I don't think we would be in this position without it. Mitigation efforts such as, I guess people call them the non-pharmaceutical interventions, right? The masks and all the other stuff. I mean, that's certainly a lot of the effort, right? But it's not all of it. And, so the ability to test and sort of isolate infected people from the rest of the population, I think is also a big part of this, especially for this. And I'm just going to say it's stupid virus. This virus is just so weird and it's so stupid to try to control. It's just so frustrating. So much asymptomatic spread and it just, there's so many factors that just were like the perfect storm that just made this whole thing just so incredibly challenging, from, the asymptomatic spread to, the huge range in symptoms of disease, signs and symptoms of disease and outcomes. And then on top of that, the complications that arose in our society with respect to the response to it, political, behavioral, social, I mean, the whole thing. It's been interesting to watch. I'll just leave it at that.
I don't know, Adam, I'm sensing a change in your tone. As a virologist, I remember you speaking with this virus with a little different light early on. Now,
in what way?
I'm surprised to hear you calling it stupid now.
I'm done with it. I'm done. We're over a year into this thing, and I'm done.
I agree. I think
coronavirus. in fact, when I teach virology next time in next spring, I think I might just skip coronaviruses. No, I'm kidding. I got to cover them, but everyone's just tired. Everyone's tired. But luckily, there's some good news. We'll get to that. Just for the average, person, on campus who, maybe isn't on the task force or, in the know for various things. Could you just walk through a little bit what we're doing for our testing protocols? Like, for example, how many students per week, or, how that works?
So as far as the athletes go, there's specific requirements depending on whether the sport is considered tier 1, tier 2, tier 3 as far as risk levels. Interestingly, I'm part of the PIAA Sports Medicine Advisory Committee, and we had our meeting last night. And the National Federation has now removed that tiering system for athletics. So they've moved away from that. And basically, the reason they're doing that is because there is more and more information that outdoor sports is much, much less risky than indoor sports.
Mm-hmm.
It
also goes for outdoor dining versus indoor dining. The studies have also shown that as well. When they've done the contact tracing, I think it's like less than 1% of known cases have come from some sort of outdoor dining event. So.
It does definitely make me so hopeful for spring and summer this year.
Mm-hmm, mm-hmm.
But anyway, we're doing the testing. So for basketball, for example, 100% of the athletes are tested 3 times a week with antigen tests. So our basketball teams, men's and women's basketball, are getting tested 3 times a week, as well as the coaching staff and the training staff. For the other sports, we just started spring sports, so lacrosse, women's and men's lacrosse, softball, baseball. 50% of the team gets tested 3 times a week.
Okay.
So we have a system where we're alternating those. As far as our regular student body, we're starting out with we did 100% of return to campus testing. So everyone residential as well as commuter students, when they're coming to campus, all got tested. And now for surveillance testing, we're going to start out with 25 students per week. And based on positivity rates, we will increase that. We have a plan with a green, yellow, and red zone where we'll increase the amount of testing based on positivity rates. So, not going so far so good. We did have a case on campus, but we've isolated that case and did contact tracing here on campus, and our students have been great. Agreeing with isolation and quarantine measures. Some went home, some stayed, and we tested them all initially, and then a couple have developed some symptoms. We did some retests, but so far so good.
Mm-hmm. Okay, good. Yeah, I mean, it's sort of a balance between resources, time, and sanity, I guess, for you, right? I mean, I guess in an ideal situation, you can envision testing every student on campus, I don't know, twice a week, right? Or something like that, or even every day, right? But there's no money, there's not enough money in the world to really do that. And also who's going to do that on campus, right? Because of your time, which is also precious. So it's sort of a balancing act. So I like where we're at, and I like that idea of ramping up if we feel like we need to. And is this sort of a random, like, name out of a hat type of situation?
More of a representative sample is what I'm calling it, because we're trying to get. Basically, the plan is to get a student from each floor, from each dorm.
Yeah.
And that way, we're hoping that if there's a hot spot, hopefully we can catch it.
Sure. Yeah, that makes sense. Yeah. So Josh, so it seems right now cases are coming down, and so there is some good news. We're also, talk about in a moment. I wanted to make a note. I made a note here about the J&J vaccine. We now have 3 emergency youth authorization vaccines in this country, which is great. J&J says they have millions of doses, like basically ready to ship, and so we'll touch on that. But yeah, so cases are coming down, and personally, I mean, I have my own thoughts on it. I'll just sort of share those, and then I'll ask for yours. But I don't think there's been really any change in behavior, right? I mean, there was a huge spike around late December, January through January. Then it started to come down. I don't think really behavior has changed too much in that sort of intervening 2 months. If anything, people would be more indoors than not, right? Because it's still cold. It's not like summer, where you might have a gathering on your deck, or at some sort of outdoor game of some kind, or whatever it might be, right? Also mostly indoors, especially in the Northeast and Midwest and the Northwest, right? The whole basic upper tier of the country, it's still cold, and I have a funny feeling that this might be mainly due to some kind of herd immunity going on. The CDC I saw recently, they looked at how many people had been, had received a positive test in this country, and then kind of extrapolated to how many people have probably been infected since last March, who maybe were never symptomatic, or who were mildly symptomatic but didn't seek a treatment, didn't seek a test, things like that, right? So, and their estimate was somewhere in the vicinity of like 80 to 90 million as of right now that have been infected. And of course, infected people probably have some kind of immunity, at least for 3 to 6 months. I'll just, we don't know long term, but probably 3 to 6 months, the immunity is pretty good. And even longer than that, it probably protects against severe disease, maybe not symptoms, but probably severe disease. So, that in combination with, at this point, Josh, how many vaccines have been rolled out? I tried finding that this morning. I couldn't find an easy answer. Do you happen to know a rough estimate how many vaccine doses have gone into arms so far?
I don't. I would be able to find that pretty quickly, though.
Yeah. Maybe
I didn't present yesterday. We didn't have pandemic yesterday.
I know. Yeah. Maybe a different site. I tried looking at that real quick before we started recording, and it wasn't popping up for me. But anyways, yeah. So when Josh looks that up, I mean, I would say that people with vaccines and natural infection, I mean, we're probably over 100 million people, which is roughly a third of this country, and maybe I would say I think that's making a dent in this. We're still having 60 to 80,000 cases per day, but it's no longer in the 200,000, 300,000 range as it once was. And so, I mean, that's my speculation, that we're seeing some effects of herd immunity here. So Josh, what do you think? Do you have different thoughts on that, or sort of a different view as to why we're seeing this plunge in cases right now?
No, I agree with you 100%, which is funny. We didn't talk about this at all beforehand, but I agree with you 100%. It's funny to me that well, I guess some media outlets, I guess is the only way to say it, are trying to say that mitigation efforts are making these improvements, and that I think that's almost laughable, honestly. I mean, I don't know how anyone could really make that argument. Besides the point that obviously for holiday travel is a big thing.
Sure.
But honestly, we started to see the last wave started 2 weeks after Halloween. It really, I mean, it continued to ramp up, but if you look at that curve, it started, before Thanksgiving travel.
Josh, I'll try to pull that up while you're talking. Okay.
Yeah. And so yeah, certainly all the travel that happened during holidays made a big difference. But I would say that just because people aren't traveling for holidays now, that doesn't explain the drop in cases that we're seeing. And certainly, even though I have seen more students wearing double masks. And so there are a lot of people that are following guidelines as they change as far as mitigation efforts go. But here's my take on it, Adam. It's the same. It's like our little college here is a microcosm. We have a majority of students that stay in their rooms and are wearing their masks when they go out and are social distancing, and they're doing the things that we've asked them to do. They don't want to get sick. They don't want to get anyone sick, and they're doing those things. Then we have a smaller but substantial population that, for whatever reason, whether it's mental health, they just can't stay in their rooms. They need to be around people. I understand that. I'm more of an introvert myself, but I understand that extroverts need to be out and about and be around people, and need that social interaction, engagement for their mental health. But they're the ones that are, that unfortunately are at risk to catching it and spreading it. And so my hope here is for the college is that, just like you said, we have some herd immunity in that group, because those groups tend to be together. They're together. They just have larger inner circles than what we would like to see. But out of those large circles, a lot of those kids unfortunately caught COVID and have been sick, but now hopefully have immunity for the semester. And I think that's what we're seeing on the national level too, is that people that have been around and have not really followed the efforts, unfortunately they caught it and they spread it. But now there's some natural immunity and a lot of natural immunity. Like you said, the numbers are pretty impressive. And now we add in the 100, I don't know. I'm not sure what the number is for vaccinated, fully vaccinated. I didn't find it.
You jinxed it, man. You jinxed it because you were like, oh, I could probably find that really quick. You got all cocky about it.
I did.
I couldn't find it either. I want to say it's maybe 15 to 20 million at this point. But
on the Pennsylvania Department of Health, that's what popped into my head was the Pennsylvania DOH, which only has our Pennsylvania numbers.
Well, what is Pennsylvania? Actually, Pennsylvania is unfortunately one of the lower states in terms of vaccine rollout, which stinks. So what is PA's?
No, I didn't find that either, Adam. Come on, I'm just saying that's the one I was thinking I could come up with.
Oh, I see. Sorry, I thought you said that's the one. That's the only one you could find. Sorry. We need to work on our communication today, buddy.
No, I know. It's my fault. It's my fault.
No, it's not.
No, like I said, I was the one that said I could find it. At least one dose, 1.9 million, fully vaccinated, 868,000. This is from the Our World data.
Okay.
Which I think comes out of University of Washington, I think is where this comes from. And that's, 1.9 million and 886,000 for fully vaccinated, which is 6.8% of the population.
Okay, so you combine that with the people that have been exposed, infected, known and unknown. Yeah, I think we're
well, and the one dose, the one dose, Adam, is really probably pretty good, especially if you had COVID.
And there was a recent study that recent preprint I saw that the efficacy continues to go up the longer after that first dose, which is probably due to the immune system kind of maturing, and it without getting the details, it can change, and actually the antibodies can become higher affinity binders and things of that nature, a little more the vaccine response, the immune response can mature and get better over time. I think that's probably why that's happening. But yeah, first dose efficacy continues to rise. They were looking at people, there was some study where they're looking at people who had their second dose delayed for various reasons. And they saw, good efficacy there as well. Still recommend getting 2 doses though. The antibody titers, the amounts go way up after that second dose. And that's the way the clinical trials were set up. And so that's what I think we should continue to push, is to get these complete doses. And there's also something I saw recently, Josh, of people that have had COVID, that perhaps that first dose could be treated as like a a second dose booster, which I think makes sense, and perhaps they don't have to get a third. But the CDC and other organizations are still recommending doing the 2 doses until there's a study to sort of show that we don't need to do that. It's not going to hurt to get that 3rd dose, and so that's what they're still recommending.
I think I saw that same article, Adam, where they were looking. I think it was healthcare workers. It was a relatively small number, but the boost in titers was pretty impressive.
Yeah, so Josh was trying to lay that out. He did a good job explaining it. So I just wanted to throw up here, the current numbers here. You can see that yesterday there was just shy of 60,000 cases reported that day. But yeah, you're right, Josh. I mean, it started to peak about mid-October, right? I mean, you can see, not peak rather, but started to ramp up in roughly mid-October. And the holidays, to be honest, I thought I was going to go up more than it did. I thought we were going to hit 500,000 cases a day around Christmas and New Year's, and maybe we didn't because of a growing herd immunity kind of percolating in the background, perhaps. So yeah,
I'm always amazed whenever if I come away from this chart for a while, Adam, and then I come back to it, and I always think back to this early on, this first wave, and thinking, oh my gosh, it's amazing how many people are getting sick. And then you look at where we are now, and it's sad.
Yeah. So, what do you want to say about the J&J vaccine?
I'm very excited about it. 1 dose is great. The stability of it still ships frozen, but you have 12 hours after it thaws to give it, and it just requires standard refrigeration. So it's I think it's going to be. I don't want to say. I mean, I think any additional vaccine we get is game changing at this point, because it's gonna get out and be used. But for the longer term, being able to get it to places, maybe places that have done well with their mitigation efforts and don't have herd immunity. Australia is I guess a prime example, but a lot of Africa has done very well. Surprisingly, I feared that basically the entire continent would be more like Brazil than what they've been. But I actually had a conversation with one of our students who has family in Africa, and we talked a little bit about. I was asking questions because of my surprise, and what the student told me was that in Africa they've been face to face with Ebola, and they know that this stuff is for real, and they know how to do these mitigation efforts. And so that's just one take, and maybe that's not the answer, but it certainly makes sense to me. That if you have buy-in of the community of the population, that you have a good chance to halt this with the non-pharmaceutical measures, like you said.
And I think along those lines, some of the Asian countries, right? Like I believe, is it like South Korea, Japan, some of those Asian countries, it's just sort of part of their sort of just culture, right? That okay, I'll wear a mask, like for like flu season, right? You see images of trains and bus stations and different things, and a whole bunch of people wearing a mask. It's just more accepted there. When
you have avian flu in the background every year, where it could they worry about this on a routine basis, like you said.
Yeah. So a lot of those countries in sort of Asia and things like that, they mask usage is just part of a norm. Like nobody's going to judge you if you have a mask on, because you look on the train car and like everyone else has a mask on, and that was just for flu season. I mean, I don't want to sort of make light of flu, because flu is a serious illness as well, but that was back when we quote unquote just had flu. And by the way, I just wanted to point out, just because I always find this interesting, we've never panicked about flu. And I don't know if it's because it's been with us for so long and we're just maybe more used to it. but an average flu season kills about anywhere from 20 to 100,000 people per flu season. It depends on the severity and different things. But say let's just say on average maybe 35,000 to 40,000 deaths per year in this country alone related to influenza virus. It tends to be concentrated more in the very young and very old. But yeah, I mean, it's not something that really grabs headlines. And I don't know, what's going to happen. But oddly enough, there really has been no flu at all. I think that goes to show the non-pharmaceutical, sort of interventions. The flu rates in this country have essentially almost gone away. They're almost non-existent for this flu season. So that'll be also interesting what happens next flu season and how that affects the virus and the virus evolution going forward. So it's a whole nother thing that we could talk about sometime in the future. Can I just, if maybe I want to comment really quickly on the whole Africa thing, because I wasn't going to bring it up, but you brought it up. And one thing that I wonder, this is something I talk about in immunology class sometimes. Have you heard of the hygiene hypothesis?
Yes.
So, and there's probably way more than just one explanation. A lot of things, it's a combination of things. But I mean, if you look in westernized countries, Europe, United States, etc., more, a little more advanced in terms of like public health measures, whether it be sewer systems or cleanliness, screens on the windows, like all that kind of stuff in combination with modern medicine. I mean, if you look in those countries, the rates of allergy and autoimmune disease, especially like inflammatory related autoimmune diseases such as Crohn's disease and rheumatoid arthritis and things like that, and allergies, they're just through the roof, and they're continuing to rise. My understanding is that they're continuing to rise even today. Yet, if you go look at, I don't know what the politically correct term is to use nowadays, so I apologize. But if you look at more, developing nations, right, sort of, or underdeveloped. When I was in school, people would say third world country. I don't know if that term still applies, but sort of, basic countries that don't have all of the things that we have, in terms of public health, etc. If you look at rates of inflammatory autoimmune diseases and allergy, they're the opposite. They're more rare. They're just more rare. And some people, and it's a very interesting hypothesis for me, is that the environment that we live in is so clean that we're just not exposed to as much, I'm just going to say stuff like parasitic worms, various bacterial infections, viral infections. We're just not exposed to as much stuff anymore. And even when we are exposed, the immune response generated isn't exactly the same, right? And I'm not saying anything against vaccines right now, but right, everyone's vaccinated for all these preventable diseases, which is a good thing, but we're not experiencing the infections in a natural way. And I'm not saying we should, but there's a whole bunch of things that people have come up with. And so if you look at Africa, so a lot of people in Africa are exposed to just more infections overall. But the thing that really intrigues me as someone who likes immunology are these parasitic worm infections. So, a parasitic worm infection is a very different immune response than to say a virus or a bacterium, right? It's just a very different response and sort of a balancing act, and one actually inhibits the other. So like an inflammatory response that fights a virus is going to actually inhibit a response that would be more tailored toward a parasitic worm infection, or vice versa, right? If you parasitic worm infection kind of inhibits this inflammatory response you might have against a virus. And there have been some doctors and trials, and again, I don't know the extent of the testing. It's just intriguing to me. But there are some people that try to treat Crohn's and inflammatory bowel and stuff by giving people say a bovine tapeworm or a pig, fluke, which is like a worm. And sometimes they see actually short-term, I don't know about long-term, but short-term reduction of inflammation and of symptoms because of this yin yang between these responses. And I just wonder, because in Africa, there's so much exposure to these like parasitic worms and just infections overall that people's immune responses are just different. I don't know what exactly that means. They're just different. And perhaps, again, Josh, it goes back to a lot of people that end up in a hospital, they have this over exuberant inflammatory response to the virus, to coronavirus, and it leads them down this cascade of events, whether it's clotting issues, whether it's swelling and fluid buildup in the lungs. That's all related to this sort of overinflammation. And I just wonder based on things that I've read that maybe this exposure to perhaps parasitic worms in Africa, and maybe their immune response is a little more tempered, a little more mature. It's just different in some way where you're not prone to that sort of overexuberant inflammatory response. I don't know. It's just something that I find really interesting. It's just too convenient in my own mind that, the one continent or in the areas of the world that, aren't quite so clean, so hygienic, they're have lower rates of coronavirus infections and deaths. I mean, that's just what the data has shown. So that's kind of like an overview, kind of threw a lot of stuff out there, but that's something I think a lot about when I teach immunology. I think it's a fascinating part of immunology that we still don't have a lot of hard answers to yet, right? Like, why is there so much asthma and allergy in the United States and really not in some African nations and some developing countries, right? There's something real going on there. So anyway, I was talking for a while there. So what are your thoughts?
That's very interesting, Adam. And my personal theory, and I believe this for a long time, and we're slowly catching up, is just, it's amazing how little we know and understand about our microbiome.
Right.
And that's just of course, I'm reading more and more about the bacteria involved in that, but you bring up another great point with parasitic infections and how that contributes. But I go back to when I was in med school. When a patient had diarrhea, we would send out for stool studies, and you would send it for a stool culture. That was part of the long list of things that you looked at. Things are much more tailored now, but back then we would get. So I remember getting the first result for a stool culture, mm-hmm. and it said normal flora, and I was like, well, isn't this should be growing something, right? Like, what is the normal flora? And I couldn't get a good answer from my mentors, and it was really frustrating to me that was not something that could be explained to me. And here we are, oh my God, almost 20 years later, 18 years later, and still we don't have good information about just that kind of simple, simple concept. And I understand now a little more about why it's so difficult, because as what's in your microbiome in your mouth changes as you get to the stomach and the small intestines, and so with the stool culture, you're simply measuring what is coming out the other end, and so.
Right.
But there's so much to it. There's so much to it, and like you referred to Crohn's disease, and in a similar vein, probably 8 or 9 years ago, they started studies with fecal transplants. So taking stool from a healthy individual, screening it, and then putting it in a patient with Crohn's disease or ulcerative colitis, and the effects were pretty dramatic. They're working on capsulizing, a product so that it can be done in a different way.
And then perhaps even growing up bacteria in the lab, if we could identify what species are in that sample, right? Maybe it's 18, 15, 12, maybe we can grow them in the lab so we don't rely on a transplant. Yeah.
It's a simple, it's a relatively very simple concept.
It's so elegant. Right? It's so elegant. Yeah. It's gross, but it's elegant, right? Can you be gross and elegant at the same time?
But it's
Yeah.
amazing to me where we are with medicine with some of the things we could do. But then I feel like there's basic principles that we don't understand, and
Yeah.
that's what the article that you sent that we're probably going to touch on at some point. I think goes towards that sometimes you have to define the problem much better to actually move to the solution. And I think while I think we sometimes have some arrogance in our belief that we understand things much better than what we do. And then, like you said, there's a lot of good, there's a lot of observations that are out there that we probably, if we could explain those observations, we would be better off because we would have a proper heading.
Right. Right. And we need like trials, right? Like sort of evidence-based approaches for these things, right? It's hard in the present pandemic because you don't really have that, right? But now we're starting to get some trials come out. Like for example, a couple of monoclonal antibodies that you can inject into somebody. They've been showing great promise as long as you catch the person within the first week of infection, when there's a lot of virus around. It can help maybe reduce the amount of virus, and then that might reduce the inflammatory response to come. So yeah, there's all kinds of stuff that's coming out. So I think in the interest of time, maybe we'll do the article next discussion, because I know you have a meeting soon, and I have to go as well soon. But you brought up a really good point though about I love the whole microbiome concept as well. We talk about that in microbiology. We actually talk about a study, Josh. It's funny you bring up fecal transplants. We go through. It was the first peer-reviewed, like double-blind, placebo-controlled study with patients that have recurrent C. diff infection, which is a bacterial infection causing severe diarrhea and other things. And these poor people were having, like, on average, like 6 to 8 bouts of diarrhea every single day for months, right? And they were essentially cured for as long as they followed the patients in the study. Like 6 months later, I think it was, they didn't have recurring C. diff in the vast majority of those patients. And so, I mean, you look at that, and I think, yeah, you're right. The bacteria that are in and on us play I would say a big role in our health and disease, and we just don't know that much. And we also don't know cause and effect, right? Because if you mentioned Crohn's, so people look at using advanced like molecular techniques nowadays, but they look at the bacteria that are, say, in the intestine for people with Crohn's versus sort of quote unquote healthy controls. People with rheumatoid arthritis, people with autism, people with X, Y, and Z. And in a lot of those, conditions, disorders, whatever you want to call them, there's just a different microbiome. It's just it, right? There's something different. But what we don't know is it, what's cause and what's effect. Right?
Even
So that's
even alcoholism in
right.
EA patients.
That's right. Yeah, yeah.
How,
Right.
it's
Something you
almost
would never.
no, it's almost a frightening thought to
Yeah,
think that there's bacteria in our system that are probably driving our behaviors.
yeah. And I don't think it's like sort of the only cause, but it might be a contributing factor, and in some cases, maybe even a major contributing factor. So there's the next 10 to 20 years are going to be so interesting to see what comes out about the microbiome and to see what's truly cause versus effect. Like, for example, there was a study we talk about in microbiology sometimes where they had mice, that it's a certain strain of mice that they're prone to having sort of like social behaviors that are consistent with autism, right? And they supplemented their food with a strain of bacteria. I think it was Lactobacillus rotari. It just part of the flora or the microbiome of some individuals, and those social behaviors changed, so the mice became more social. They were less nervous, stressed, all these different things in this mouse model, and that was just giving them a single strain of bacteria in their food, right? So there's and that's not to say that there's going to be like a magic pill to take for everything, but it maybe will help mitigate the effects, right? So maybe whether it's Crohn's or autism or alcoholism, maybe you supplement almost like a probiotic, right? And maybe can help reduce the symptomology or the effect of the disease. And I'm certainly not calling, so some of that a disease. I wouldn't consider autism a disease. I don't know if you call it a condition or whatever, but I'm sure somebody would, if they could reduce some of those effects of autism, they probably would elect to do so, especially some of the social aspects. So anyway, yeah, there's just a lot to learn, and it'll be interesting to see what happens. But you're right, the whole microbiome thing is super interesting. I would, go on a limb and say that people are looking into this, but I bet you any money that if you look at people that end up in the ICU with COVID-19 versus not, probably their microbiome might be different, right? And what that means, again, we don't know yet what's caused what and what's effect, but I'd venture a guess that they're probably different in some way, and maybe that contributes a little bit. So, well, great. So yeah, I think we both have to get going, but this is, again, I always enjoy our conversations, and I hope other people do as well. And again, please write in if you have any questions, about the vaccines or the pandemic, or really anything else. Be happy to discuss it, or, send us some feedback. So this concludes episode 16. Thank you, Josh, for carving out some time. I know you're very busy.
Yeah, thank you, Adam. It was a pleasure as always. I really enjoy these.
All right.
I hope other people do too, just like you
Yeah.
said.
Yeah, me too. All right. Take care.